Well, when I think of a high CV risk patient and what target levels, the first thing is I think of the threshold is when do I need to intervene? And that tends to be usually around an LDL of around 70, but important also to think of non-HDL cholesterol of 100. Why? Because a lot of our patients with diabetes, heart disease have high triglycerides. The LDL may be 60, but the non-HDL is still over 100. So those are important to consider. There's some people measure ApoB. That would be another alternative route. Now, when I treat somebody, once I've made the decision, it depends upon a couple of issues. One of them is the availability of which therapies are open. Some of that's a financial consideration. Ezetimibe is useful for patients. It does lower LDL on top of statins. If I've got a really high-risk patient in these situations, and if they can afford a PCSK9 or available, and that depends upon in the United States, the programs. But I find that that's the most effective therapy to really drive the LDL down. And I don't have a goal. When I use that, I try to get my LDL as low as I can in these patients. And it's an educational issue that if they see an LDL that's 20 or 15, that's actually wonderful. It's not a problem. That's a good thing because I know I've gotten their risk much lower.